Namaste to all the lovely doctors of this country. A very, very warm welcome to this wonderful evening for Fmge recall session for surgery questions asked on 12th of January 2025. Lovely to be with you once again, and I'm pretty sure that all the lovely doctors of this country would have used their nice clinical acumen and lovely good evening, Nikhil. Lovely good evening, Savan, Krishna. Wonderful good evening. Kaisa raha beta paper? How was the paper? The information which we are able to gather from different students, different sources, suggests that paper was on the moderate side. It was not an easy paper. It was not very difficult or not doable paper, but yes, the questions were moderate, and in some subjects it was moderate to difficult as well. Right. If we focus on surgery, then surgery was also towards the moderate side. It was not on the easier side. If we look at all the complete questions related to surgery. Great, Savant. Wonderful. Sandeep, lovely good evening. Khanna, Krishna, lovely good evening to all the lovely doctors. So let us quickly take a look. Approximately, I've been able to summarize around 31 questions from surgery, along with 12 questions related to the other subjects, the overlapping subjects. Right. So let's take a look. We'll be going in a sequence starting from pediatric surgery, then adult surgery, then oncosurgery, then something related to trauma, vascular, endocrine, and some miscellaneous topics, just like the indexing in the workbook. Surprise thing in this particular surgery paper was there were just 2 questions related to pediatric surgery, and trauma was also not able to constitute to that many questions what we generally expect. So the division of these questions was taken mainly by the oncosurgery part and by the miscellaneous part. So let's take a look at these questions one by one, beta. Right. Lovely, Savan. That's really good. Okay. So 18-day-old baby was brought to the hospital with vomiting, failure to thrive, and a mass in the epigastrium. Which of the following is the most likely diagnosis in this baby? Now, in this particular question, the thing which I feel is the age, whether this age was mentioned or age was not mentioned, or was the age a bit on the higher side. So please do correct wherever possible, beta, with whatever memories or whatever recalls you have. And this is just based on the discussion with the students, not an exact recall. But yes, I have tried my level best to have a nice glimpse of the overall paper. Right. So, wonderful. So I think all the lovely doctors would have not committed mistake in this particular question. If there was a mass in the epigastrium, there was vomiting, there was failure to thrive, and it was not immediately after birth. For example, duodenal atresia would be presenting immediately after birth, within few hours, maybe 4 to 6 hours. It was mentioned 45 days. Okay, Yash beta. Yes, so let me correct this. I think as Yash is mentioning, it was 45 days. Okay, right. So this is what I also received the information from students, that it was not a classical 3rd week. So 2 to 6 weeks old is generally we find this hypertrophic pyloric stenosis. This would be found in the newborn baby, maybe within few hours or maybe first, second day of life. And this esophagitis would be seen somewhere in adult, and gastric cancer obviously in elderly person. So as we know, age is not just a number, it is something more than that, right? So out of these 2 options, the correct answer was hypertrophic pyloric stenosis. That's right. Fine. Now let's move to another question. Now in this particular question, we are finding a lot of different opinions as well regarding the age of this particular question. This is a 27-year-old patient presented with melena and intermittent pain in the right iliac fossa. On examination, there was tenderness in the right iliac fossa associated with nausea, vomiting type. He was operated and the following was found in the image. Right. Now let me just try to figure out. All the lovely doctors, Savan saying K, saying C, K is saying C. Let me have few more answers. Right. Okay. So what is the game here, beta? If suppose it actually depends, the answer will depend on what was the image given in the question, right? Because if it is an appendiceal cancer, generally the age should be a little on the higher side, or a cecal cancer would be on the higher side, though I doubt that cecal cancer was there in the options or not. So now appendiceal serous tumor and Meckel's diverticulum. Now, if this is or something similar to this image was there, right. So med carrier beta or Sindhu, was there something related to acute appendicitis in the option? If it was just a mucocele gash and it was not inflamed, that means it is not going in favor of okay. A mucocele would not be presenting with appendicitis unless until the appendix gets inflamed there, right? But in the question, if they're suggesting some features like med carrier is pointing out that there was fever as well, image was little different. Okay. So Nikhil beta, let's see. I was just trying to gather few images related to serous tumor in the appendix, like this particular image what we are seeing beta. This is the serous tumor in the appendix. Okay. Krishna is saying rebound tenderness was positive. Med carrier is saying mucocele of appendix was there. Okay, right. We'll figure out Shivani. Why not B? Okay, so one small little thing which I would like all the lovely doctors to focus on, that if suppose you were able to see the tinea coli on the cecum, and then very close to the cecum you were seeing this tubular structure, then it is going in favor of appendix. So maybe the examiner, if he's trying to confuse you with appendix, he might have given an image where the tinea coli would have been shown, right? So just try to recollect if there was some tinea coli type of thing given. And this is actually appendiceal malignancy, what you're seeing here. Now, in this image also, if you try to figure out, then this is the tinea coli, which is present on the cecum. This is the tubular structure, which is hanging from the lowermost part of cecum. And this is a tumor in the appendix. Okay. Okay. So Yash is saying that image was little similar to the first picture. I would like to know from Yash, are you talking about this? Okay, Kshitija. So it was just similar to the workbook. Let us also just try to figure out our workbook image. Right. So this is the image beta, which is there in our workbook for Meckel's. Okay. First one resembles more. Okay. So Kshitija, this is the image which we are having. Daksh. Okay. Okay, Anna. Okay, Daksh. So, okay, Kshitija. Then definitely the answer goes in favor of Meckel. So now there is no confusion, absolutely. Right. So let me hear from everyone. Nikhil is also saying same. So if all of us are on the same page, then definitely no confusions now whatsoever. Okay, got it. So maybe because I've edited this. So now I think there should not be any confusion in this, and the answer goes in favor of Meekles. Islam is saying 80% almost, yeah, because probably I would also have morphed that image before I would have put that in the workbook. So most likely, right. Great. So all scores settled for this, and the answer would be Meekles. Okay. Now another question, beta. A 40-year-old lady presenting with dysphagia, initially for liquids and then for solids. Now this is a classical picture what we know about idli sambar, right? So in eclasia cardia, what happens? There is spasm of the lower esophageal sphincter. If the patient takes the solid food, then because of the weight of the solid food, the food will relax the lower esophageal sphincter and the food will go down. But if the patient is taking only sambar, then sambar does not have that much of weight, so it will not be able to relax the lower esophageal sphincter muscles, and sambar will attack. Sambar will get stuck. So initially there will be dysphagia for liquids, and then gradually for both liquids and solids. Right. So this is a classical history. The age of presentation for eclasia cardia is generally around 25 to 40 years. Right. So eclasia, we know it is 25 to 40 years. Now, which of these signs would be seen in this, Daksh? Okay, beta. So there is smooth tapering. Okay, only liquid, not for solid. Someone is saying red tail. Very good. Right. Okay. Fine. So basically, in eclasia cardia, there is abrupt tapering at the lower end. We can find rat tail appearance in cancer esophagus as well as in eclasia cardia. However, it is more often related to cancer esophagus, but it can be seen in eclasia cardia also. Okay, nutcracker esophagus, we know there is a corkscrew type of appearance, and irregular filling defect is seen in cancers. Right. Okay, so instead of nutcracker, as you are saying, the option would have been corkscrew esophagus. Okay. Okay, Krishna is saying first for liquids and then for solids. Fine. Whatever it is, the answer goes in favor of rat tail. Wonderful. Right, Nikhil, बिल्कुल. यहाँ सांबर आया इडली NB वाले. Right. Okay. Corkscrew was there, Vikram. Right. Thank you, beta. Thank you so much. Now let's move to another question. Now this is a question which just try to recall whether it was there or not. 47-year-old male was admitted with complaints of constant chest pain, heartburn, dysphagia, and sometimes regurgitation. Now, heartburn, regurgitation, this all goes in favor of GRD. But he is also mentioning about dysphagia. And the pain is worse after eating. With fluorogastroscopy, the insufficiency of the closing apparatus of the cardia is revealed. During X-ray, a gas bubble with horizontal level is observed against the background of the shadow of the heart. Make a clinical diagnosis in this patient. Okay, Yash. Right. So Dr. Alam is also saying no. Okay, so there was nothing of fluorogastroscopy. Wonderful. Okay, fine. So if this question was not there, but yes, now if suppose you have to mark the answer for this question, wonderful. Wonderful. Great. So there was nothing like this. Now, if in this, wonderful, Dave. Thank you very much. Right, Richard. So everybody is on the same page. This type of question was not there. Great. Now, if suppose this question was there, because we have put it here, if there was a horizontal level observed in the thorax and there are features of dysphagia and all, then the best answer for this question goes in favor of paraesophageal hernia. Right, so let us skip in this. Now this, another question. A patient presented with diffuse abdominal pain, where on clinical examination, there was tenderness all over the abdomen with abdominal rigidity. Plain X-ray showed the following. What is the likely diagnosis? I hope all the lovely doctors who appeared for this particular exam, they know that there has to be at least one question from three areas. Either it can be a story related to intestinal obstruction, where there might be single bubble, double bubble, triple bubble, multiple central, multiple peripheral bubbles, or there can be a question from gas under diaphragm, or there can be a question from pneumothorax hemothorax. Right. So yes, that question I have included. But yes, you have added nice language to that question. So we'll be adding that language, yes, once we reach there. Now, in this particular image, beta, just try to figure out what is this. So I hope. Wonderful. So epic, Ashish, cardboard word was mentioned. Very good. So over the abdomen with cardboard like rigidity. Wonderful. Okay. So beta, इसमें तो I don't think there is any doubt or any confusion. So we can straight on mark this. We are able to see the gas under diaphragm, and a lot of students told me that we were able to see gas under both domes of diaphragm in this particular image. Right. So this goes in favor of perforation peritonitis. Wonderful. Great. Now moving on to another question. I think you would not have faced too many issues in this. A lady was being investigated for infertility, wherein hysterosalpingography was done. Now for further evaluation, laparoscopy is being done, wherein the following instrument as shown in the image is used. So what is this instrument? Okay, so let's try to zoom this instrument, and all the lovely doctors, you know the answer. Okay. Wonderful. So absolutely correct. It was Veris needle. All laparoscopic surgery, when we have to create the pneumoperitoneum, then first of all, we make an incision over the skin, and then we put this Veris needle, connect carbon dioxide gas, and try to achieve an intra-abdominal pressure of 10 to 15 millimeter of mercury. Generally, in laparoscopic surgeries, we keep this intra-abdominal pressure as 12 millimeter of mercury. Right. So absolutely correct. Now, moving on to another question. This question, I would definitely need help from all the lovely doctors watching this session, beta, regarding the options in this particular question. During laparoscopic surgery, while inserting the trocar into the abdomen for creating lateral or paramedian ports, which of the following structure is more prone for injury? Right. Okay. So Krishna XYZ Kshitija. Okay. My voice is breaking. Okay, let me just to bring the mic a bit closer. Fine. Now let us see. Okay, in this image was there. Shivam beta, McBurney sign was positive in Meikle's question. Meikle's, when it presents with symptoms, it can mimic acute appendicitis. So Dr. Alam and Tom is saying that superficial and inferior both in the same option. Okay. A was only circumflex. Okay. So it was not circumflex iliac. It was just circumflex, as you say. And superficial and inferior epigastric artery both in the same option. Okay. Then the game is done. Then there is... okay, so there was no image. Okay, then this is the best answer. Right. So if superficial epigastric and inferior epigastric are given in the same option, then that is the best answer. Right. Thank you, Yash. And if by chance suppose superficial epigastric and inferior epigastric are given in different options, then the best answer will be inferior epigastric artery. Okay. Fine. Let us just try to see this, that whenever we are making a port in the umbilical region, the most commonly injured arteries during trocar placement, especially with lateral or paramedian ports, are the inferior epigastric arteries because they run along the posterior surface of the rectus abdominis and are vulnerable during the lateral port placement. जबकि बेटा जो superficial circumflex iliac, they are located near the inguinal ligament. तो lower abdominal port में अगर if we are creating a lower abdominal port close to the inguinal area, then yes, superficial circumflex can be injured. Right. So the answer to this particular question, if both are given in the same option, that is the best answer. If both are given in different options, then inferior epigastric artery would have been the best answer. Right. Moving further. Now, this is a lengthy question. There were a lot of lengthy questions in surgery, and the time management was really crucial for this. The image, what we are seeing in this question is not the same image, but I've just tried to gather it just to understand what the question is trying to explain. So this is a lengthy question, and herein suppose this is a game of a 50-year-old male underwent emergency laparotomy for grossly contaminated peritonitis due to perforated hollow viscus. Now, on post-op day 7, the patient developed signs of wound infection, including erythema, tenderness, and serosanguinous discharge. Subsequently, the wound showed evidence of dehiscence with exposure of underlying tissues. The patient vital signs are stable with no evidence of ongoing intra-abdominal sepsis. Considering the current wound status, what should be the most appropriate management strategy for this laparotomy wound? Right. Now, suppose this is a case of wound dehiscence or wound disruption. How to manage this particular case? If we look at the options here. Right, Chitaja. Thank you, beta. So here in the options, initiate vacuum-assisted negative pressure wound therapy to promote wound healing by enhancing granulation tissue formation and controlling the exudate. Perform primary closure of the wound after thorough wound debridement to achieve immediate closure and reduce the risk of further contamination. Opt for regular dressing with saline-soaked gauze and give appropriate antibiotics based on wound culture and sensitivity, ensuring local wound care and infection control. Proceed with secondary wound closure after initial period of wound debridement and infection control to allow the granulation tissue. Now, this is a lengthy question, and what is the crux in this question, beta? The crux is he is asking how to manage a burst abdomen, basically. So obviously primary closure is not the recommended choice because we are dealing with a wound which is already infected, and all the lovely doctors know that whenever there is cross contamination, we never put sutures, right? So primary closure is out. Now secondary closure can be done at a later date if at all secondary closure was there in the option. And if Melvin is saying only VAC was there in the option, so vacuum assisted closure is what they would have mentioned. So if it was a small option, wonderful, vacuum assisted closure. Let me just put the mic on. Okay, so let's try that if this improves. Fine. So basically we have to just focus in two areas. One is vacuum assisted closure and the C option where we are doing regular dressing with a saline soaked gauze. Out of these two options, vacuum assisted closure, that helps. Okay, Melvin, rest three options were long. So vacuum assisted closure, that helps better in draining the wound infection and helping in the closure as compared to just doing the dressings and antibiotics. So A option is the best option, and this is vacuum assisted closure. Right. So here A is the correct answer. Now let's move to another question. During a splenectomy procedure. Now, here also I would like to have your help, beta, whether this question was there in the exam or not. Yeah, just try to figure out. During a splenectomy procedure for a 40-year-old patient with the ITP, the surgeon aims to ensure complete removal of all splenic tissue, including any accessory spleens, to prevent recurrence of these symptoms. Accessory spleens are commonly encountered in specific anatomical location. What is the most common site or most likely site where the surgeon should search for accessory spleen during the operation? So, or he was just asking about the accessory spleen, basically. The framing, yeah, accessory spleen. He was trying to figure out where the surgeon is going to search for accessory spleen. That's right. So splenic hilum was there in one of the option, and actually this is the correct answer, splenic hilum. Yeah, okay, Yash. Okay. Krishna, Yash and Richard, you are saying that it was there. Couples are saying no. Therapist is saying no. Okay. Options are different. Okay, the options, one was something related to omentum, one was something related to some ligaments, I guess. Where to find the accessory spleen? Yeah. So accessory spleen, first answer will be splenic hilum. Second answer will be the omentum in this. This is according to the Bailey and Love. Below the diaphragm was one of the option, okay. Below the diaphragm. If yes, splenic hilum was there, then that is the best choice. Right. Hilum is there. Okay, so this is the correct answer, splenic hilum. Wonderful. Alan is saying below the diaphragm was there. Yeah, so small intestinal loops. Okay, so if you are able to recall the options, that means this question was definitely there. Let us just try to figure out what are the important points related to this accessory spleen. Splenic hilum is the most common site for accessory spleen, as these structures originate from the same embryological tissue as the spleen and most likely to be located near the main spleen. Then splenorenal ligament and the omentum, they occasionally harbor accessory spleens, but they are less common locations. Then left paracolic gutter, theoretically it is possible, but practically we rarely find this. And gastrosplenic ligament, they are also less common as compared to splenic hilum. So most common sites, if you see here, splenic hilum, then the splenorenal ligament, the gastrosplenic ligament, the tail of the pancreas, the greater omentum, the mesentery, the retroperitoneum, the pelvic region, the left paracolic gutter, and very rarely, very, very rarely, you can even find them in the scrotum as well, right? Okay. So here the answer goes in favor of splenic hilum. Right. Now moving on to another question. Yes, so thank you so much for making me correct this particular question. The age you said was 80-year-old lady was there. Right. Okay. In the emergency with diffuse abdominal pain and distension of abdomen, she is having constipation. Okay. Okay, Krishna. So image was there in that question. Fine. On imaging, following was found. What is the likely diagnosis? So you have already suggested this. This image was something like this. May not be exactly coffee bean. Or was it exactly coffee bean as per the workbook? Let's see. So here the answer goes in favor of sigmoid volvulus. Right. So the image was different. Fine. Thank you, beta. Thank you for correcting me regarding the framing of the question. And in this question also, I would need your help because whatever I am able to gather, there were a few images on various Telegram groups which were showing IVP. Then there was something which was showing retrograde pylography, and the students whom I interacted with, they showed that they were able to see the stent clearly in this particular question. So if you are able to see the stent something like this, then it goes in favor of ureteric double J stent. But if suppose it was a IVP or RGP image, Akshay, this was not there. Okay, so instead of this, okay, Gyanendra is saying they showed the stent. Okay. Was DJ stent there in the option or ureteric stent in the option? Image was different. Okay. Okay, on one side the kidney was seen. Okay, Savan. So you were able to see the double J on the left side, and that was there in the option as well? Vikram is also saying that DJ was clearly visible on the left side. And was DJ or ureteric stent mentioned in the option? The options were retrograde pylography, IVP. If DJ was the option, then epic DJ would have been the answer. But if suppose DJ was not in the option, then I would go with RGP, retrograde pylography, because you are saying only one-sided kidney was seen. So Savar is saying DJ was there in the option. Vikram is also saying DJ was there in the option. And if you are able to see the double J stent, then definitely the answer goes in favor of no, we'll be doing, yes, some contrast study if we have to see the kidney. If it is not any contrast study, we'll not see the renal pelvis. We'll just be seeing the double J stent. But what we can do is, in RGP, I'll just try to figure it out for you. In RGP, beta, what we are doing is, suppose this is the game here, and this is the ureter, and this is the urethra. Now, what we do is, we pass a cystoscope first, and through the side channel of the cystoscope, we introduce a ureteric catheter. So, what might have been seen on the left side, what you are saying, that the examiner would have introduced a ureteric catheter like this, and then he would have pushed the contrast, and then the contrast would have been traveling like this, and you would have been able to see the renal pelvis like this on this side. If this was the game, then the answer goes in favor of retrograde pylography. So left kidney pelvis, if you were able to see the contrast on one side, and you were also able to see some stent type of thing, then the answer goes in favor of retrograde pylography. Right. Okay, Yash. Thank you, beta. Thank you very much. So, you might be seeing a ureteric catheter through which the contrast would have been put, and then the ureter was seen and the renal pelvis would have been seen. Right. So the answer should have been retrograde pylography. Fine. So Daksh and Savan, two different opinions. Whatever it is, beta. If you are not able to see the contrast, then the game goes in favor of double J stent. If you are able to see the contrast, then it goes in favor of retrograde pylography, because then it would not have been a double J stent. It would have been a ureteric catheter which would have been introduced in the lower ureter. Right. In previous question, it depends, yes, beta, if the bowel loops are dilated all over the place in the abdomen, especially in the peripheral part, then it can be a case of paralytic ileus as well. Okay, beta. So, अगर दोनों साइड के देखते सूर्य प्रताप बेटा, तो it would have been IVP. If only one side का दिख रहा है and there is a catheter seen in the ureter, maybe in the lower part, then it would be retrograde pylography. If there is no contrast seen in the ureter renal pelvis, then it would have been a stent in the ureter. So depends on what was asked. नहीं, रिट्रोग्रेड में दोनों साइड के नहीं देखते सूर्य बेटा, क्योंकि अपन तो यूरेटर कैथेटर को जिस तरफ डालेंगे ना, यूरेटर कैथेटर से कॉन्ट्रास्ट जाएगा. जैसे सपोज अगर मान लो बेटा हमने यहाँ पे ऐसे सिस्टोस्कोप डाला हुआ है और फिर इसके साइड चैनल से आई एम पासिंग अ यूरेट्रिक कैथेटर, तो अब जब मैं इस सिस्टोस्कोप से यूरेट्रिक कैथेटर डाल रहा हूँ तो आई कैन पुट इट ऑन दिस साइड and then I am going to push the contrast like this, तो I'll be able to see only this side. लेकिन अगर मेरे को दूसरी साइड का करना है बेटा, तो suppose this is the ureteric catheter, then I'll pass the ureteric catheter into this ureter and then यहाँ से I'll be pushing the contrast. तो contrast will be going like this on this side and we'll be able to see the renal pelvis on this side like this, right? तो एक ही साइड का दिखेगा ना बेटा. Okay, fine. Okay, beta. Okay, Daksh. Right. So the answer goes in favor of retrograde pylography. Fine. Now moving on to next question, beta. A gentleman gives history of falling astride injury. Now, falling astride injury was there, following which he was having difficulty in urination. Blood was present at the external urethral meatus with bruising in the perineum. Now, whether this word was there or not, I'm not sure about this. Which of the following is the most likely injury in this patient? Now, if it is fall astride injury, now fall from height, loose manhole covers, bicycle accidents, all this goes in favor of bulbar urethral injury. Road traffic accident, fracture pelvis goes in favor of membranous urethral injury and extraperitoneal bladder rupture. Beer drinking or trauma to over-distended bladder goes in favor of intraperitoneal bladder rupture. Overall, if we see, most common urethral rupture is bulbar urethral rupture. Right. So, Krishna, if contrast was visible on one side, it would be in favor of retrograde pylography. If Dr. Andava, renal pelvis was not seen, you were seeing only a stent, then it would be a double J stent, depending on the image. Right. So, Savan and IO0, absolutely correct. It was a clear-cut bulbar urethral injury. So, fall from height or fall astride injury, loose manhole covers, bicycle accidents, these are taking you towards bulbar urethra. Fracture pelvis or fracture pelvis is taking towards membranous urethral injury or extraperitoneal bladder ruptures. Right. Fine. Patient has multiple clots in urine. Which catheter should be used in this patient? Now, I would like to know from all the lovely doctors whether this question was there in the exam or not. Right. McConley catheter, 22 French Foley's 2-way, 22 French Foley's 3-way, 22 French Foley's 4-way catheter. Let me just hear from all the lovely doctors. Was it there? Okay. Wonderful. So it was there. Fine. So Dr. Vikram, Dr. Melvin, Dr. Pooja, Richard, Alan. Okay. So if it was there, beta, then we'll just yeah. If he is mentioning something like this, then the game will change a bit. Generally, what we are doing is we are using a 2-way Foley's catheter. If you see the images, beta. Now, this is the Foley's catheter which we are using generally for normal routine circumstances. It was an elderly patient. Okay. But Dr. Praveen, whenever there is some blood clots inside, then we actually have to use a 3-way catheter. In this 3-way catheter, one channel, what you are seeing, like 2-way and 3-way, one channel, this channel, what you are seeing, this is to inflate the balloon of the Foley's, and this is for urinary drainage. Now, whenever there are clots inside, then this wala channel is used for balloon, this is for urine drainage, and the third way, this is to irrigate the bladder. So we can push the normal saline from this third way, irrigate the urinary bladder, and try to evacuate the blood clots so that the eye of the catheter, jahan se urine ko drain hona hai, that should not get blocked, right? So whenever we have to drain the clots, then we are going to use the 3-way catheter. And beta, a 4-way catheter which is very rarely used, this is when we have to deliver additional medicines also inside the bladder for intravesical therapies. Right? So herein, the correct answer would be a 22 French 3-way Foley's catheter. Right? Okay, beta. Now moving on to another one. Identify the following. Now which image was there? Irrigation was also there in the question. Okay, Alan, thank you, beta. Thank you very much. So which catheter should be used in this patient which can facilitate irrigation of urinary bladder? Irrigation and clot removal. Okay. From urinary bladder. कोई बात नहीं बेटा, कोई बात नहीं. Epic. Okay. Right. अच्छा, इसमें it was similar to first image. तो कुछ इस तरह के इंस्ट्रूमेंट्स थे. तो this is a band applicator बेटा. This is used as a treatment of choice for second degree hemorrhoids. यहाँ पे आगे के हिस्से में there are rubber bands which we can put. So this is Barron band ligation basically. Barron band applicator. Right. Not the same. Okay. Something. This was there, but a different image was there. Fine. Okay. Okay. Right. So the answer goes in favor of Barron band ligator. Some small metal dots were there. Okay. Some metal dots. Now another question. A patient presented with the following as shown in the image. Which of the following will have less priority in calculating the prognosis in this patient? So this is a case of oral malignancy, or maybe the malignancy would have been somewhere towards the lip side, I guess. Linear stapler. Okay, so bizarre beta, linear stapler was in the options or in the question? Okay, let me write this as linear stapler here. Right, so Epic, you are absolutely correct beta. Lesions were on lower lip. Right. Now, histological grade, definitely if it's a poorly differentiated malignancy, the prognosis would be bad. Depth definitely will indicate deeper invasion, so the chances of spread will be high. Okay. Okay. And site is also influencing the prognosis of cancer, because if it is on the commissure side, then the chances of spread are high. So out of the given option, though duration will also affect the prognosis, but if we have to rule one out, then duration is what we can rule out in this particular question. Right. Fine. The prognosis will depend on all, but out of the four options, the least thing which we can categorize for prognosis is the duration. Right. Fine. Now moving on to next question. Acha, okay. Bizarre, I'll just note it down beta, that there was a image based question related to linear stapler. Okay. We'll just cross check. Very good, Daksh. Wonderful. Right. So now another question here is elderly gentleman diagnosed with prostate cancer, presented with low backache. What is the likely route of bony metastasis to lumbar vertebra in this particular patient? So beta, whether it is a prostate cancer or breast cancer, the metastasis occurs through Betson's lumbar vertebral plexus of veins. This is what we know about. And out of these options, He has given veins, so we'll be going ahead with venous. Right. Absolutely correct, Savan. Fine. Now, this was a direct question without any history. Okay. Okay, Harish. Thank you, beta. Thank you very much. Now, there was another question related to image of endoscopic ultrasound. Let us just try to figure out. Okay. Now, please tell me, beta, if image was something similar to this. Okay, Dr. Harish. Thank you, beta. Thank you very much. Okay, Dr. Harish. Almost same image. Okay, Dr. Daksh. Right. Okay, Dr. Harish. So it was the same image. Fine. Almost the same. Yeah. Yes, absolutely correct, beta. Following is useful for, so this is endoscopic ultrasound. And we know endoscopic ultrasound is the investigation of choice for staging when we want to know the depth of tumor invasion. So it is commonly used for esophageal cancer, stomach cancer, and even colon cancers for depth of tumor invasion. Endoscopic ultrasound. Okay. So that image which was shown in the class, fine, wonderful. Okay, so I'll just also try to see if we can see that particular image as well. Endoscopic ultrasound. Just give me a moment. Right. So this is the okay. Right. Let us just try to figure out if at all this was there. Oh, Dr. Pooja, couples Krishna, Savan, exact same image. Oh, okay. Okay, so this is a classical endoscopic ultrasound image. Wonderful. So there is no confusion, no doubt. Wonderful, beta. Savan. Fine. So the correct answer for this would be staging of the cancer, right? Fine. So I hope you would have marked it right. Okay, beta. Now, there was another question. Okay, baby beta. Wonderful. Right. Now, another question is 65-year-old male who presents with lower urinary tract symptoms, including weak urinary stream, hesitancy, nocturia. On physical examination, hard irregular prostate is palpated, no history of significant illness, but reports back pain over the past few weeks. Physician suspects prostate cancer. Which of the following investigation is most appropriate to assist in the diagnosis or management of this condition? Right. Alkaline phosphatase, acid phosphatase, testosterone, alpha fetoprotein. Let us just figure out. Yes, all the lovely doctors, beta. What can be the answer for this? Okay. Okay. Okay, Dr. Harish. So almost the same language, right? Yeah. So in this, for bony metastasis beta, it is the acid phosphatase. Yes, Dr. Harish, it was acid phosphatase. Okay, Daksh, if we take a look at the explanation for this, then prostate-specific acid phosphatase can be elevated in prostate cancer, particularly in advanced or metastatic disease. While it is not commonly used today due to PSA testing, it can still play a role in specific scenarios. Alkaline phosphatase is typically elevated in case of bony metastasis, but it is not a primary diagnostic tool for prostate cancer. So, Yash beta, even if, or Dakshi, even if you have marked the answer A, that means it is not absolutely wrong. But if we have to figure out between acid phosphatase and alkaline phosphatase, then acid phosphatase becomes a better answer, right? So, do not get disheartened. Both can be elevated, right? Testosterone, while testosterone influences prostatic tissue, but its levels do not diagnose the prostate cancer. And alpha-fetoprotein is for liver stories. Right. Thank you, Dr. Andava Beta. Which of the following is the most specific clinical use of PSA in the management of prostate cancer? Now, I would like to ask all the lovely doctors watching this session, Beta, was there any question like this, that what is the use of serum PSA? So one option is screening for prostate cancer, another is monitoring the response to treatment in prostate cancer patient, another is diagnosing the benign prostatic hyperplasias or confirming the diagnosis of prostate cancer. Options may not be very similar in this, but was this some similar type of question there in the exam? Okay, Dr. Yesh. Okay. Okay. Dr. Harish, Dr. Harsh, Dr. Sawan, Dr. Krishna, Dr. Pooja. Options not sure. Right. So if these were suppose the given options, then monitoring the response to treatment in prostate cancer is the best answer for this. Question same here. Options were slightly different. We'll just try to figure out what is this. Screening for prostate cancer, PSA is not recommended for universal screening because otherwise we'll have to do biopsy in a lot of people, because if PSA is high, then we recommend doing a prostatic biopsy. Monitoring the response to treatment in prostate cancer patient is highly specific for tracking treatment efficacy and detecting biochemical recurrence after therapy. For diagnosing BPH, PSA is not specific to BPH because PSA can increase in all conditions, all pathologies related to prostate, whether it is prostatitis, BPH or cancer. However, the normal values of PSA are 0 to 4 nanogram per ml, but in BPH it can increase above 4. If it is more than 10, it is suspicious of cancer, and if it is more than 20 to 35, then it indicates advanced prostatic cancer. So it is not to diagnose BPH or to confirm the prostate cancer also, because confirmatory tests for prostate cancer would be ultrasound guided prostatic biopsy, transrectal ultrasound guided prostatic biopsy. So depending on what were the options, the answer may change. Patient survival के लिए, okay. That means suppose it was not for diagnosing BPH, for survival in prostate cancer. Right. Okay. So if suppose this option was there, the response to treatment was there, then it is a better option. If this option was not there, then we do check this PSA after treatment for prostate cancer, because if the values start rising, then it indicates either it is metastasizing or it is spreading basically. Report is PSA of 15. Okay. Okay. Serum PSA levels were 15. Now, depending on the language of the option beta, the story will change. The screening is gone. Now confirming the diagnosis, if he's saying confirming the diagnosis, then no. But for survival or prognosis, then it can be yes. Now basically to sort this question out, I actually need to know all the options, and based on that only we'll be able to figure out what is the correct one. Right. So let us leave this question for future discussions. Please do ping me on my WhatsApp if any one of you is able to recall this. Now, a lengthy question again. A 28-year-old male presents with a painless swelling in the right testis, which he noticed 2 months ago. On examination, the swelling is firm and non-tender. There is no transillumination, and the contralateral testis appears normal. Ultrasound confirms a hypoechoic mass in the right testis. Additional imaging reveals enlargement of the para-aortic and pre-aortic lymph nodes. Now, if B option was there, EPIC, then it should be the correct answer for that question regarding PSA. Right. So all the lovely doctors, beta, the language of the question would be different there, but I tried to create a lengthy language because I was able to get figures from many of you that there were a lot of lengthy questions. Okay. Options were same. Dr. Pooja is saying low inguinal orchidectomy. Okay. Though there is nothing like low inguinal orchidectomy, beta. Low inguinal, I don't think so it would have been there. It is either a orchidectomy which is done by scrotal route, or it would be a high inguinal orchidectomy which is done by inguinal route. So we all the lovely doctors know that we do not take biopsy whenever we are suspecting testicular malignancy because of risk of spillage of cancer cells. So biopsy is gone. Now, whether we should do just orchidectomy or we should do a high inguinal. We don't do orchidectomy. We prefer doing a high inguinal orchidectomy. Right. Because if we just do orchidectomy and leave the spermatic cord area, there are chances that we would be leaving the malignant cells inside. So it is always better to perform orchidectomy in suspected testicular cancer from the inguinal route to remove any possibility of leaving residual cancer behind. Right. So Dr. Raghav, absolutely correct, beta. Epic, absolutely correct. Right. So all of you are on the same page now. Wonderful. So we have sorted this. This was high inguinal orchidectomy. Great. Now another question, though this question is an overlapping question with the pathology. 50-year-old female presents with a solitary thyroid nodule. FNAC reveals follicular cells with abundant eosinophilic cytoplasm. Without nuclear grooves or pseudomorph bodies, the nodule is non-tender, immobile with no significant lymphadenopathy. Right. क्या बात है बेटा. Thank you very much एपिक बेटा. बहुत बढ़िया. अब यहाँ पे बेटा किशोर एंड गोकुल, डॉक्टर किशोर, इफ ही सेइंग फॉलिकुलर सेल्स की गेम है, राइट, एंड एनाप्लास्टिक में तो क्या होगा, इट विल बी वेरी एग्रेसिव टाइप, मतलब उसमें बहुत सारी माइटोसिस होंगी, बहुत प्लियोमॉर्फिज्म होगा, पुअरली डिफरेंशिएटेड एकदम, विद अ सर्वाइवल ऑफ नॉट इवन 6 months, or maybe up to 6 months, right? 60-year-old था, okay, so this was 60-year-old. Right. अब इसमें बेटा pseudomorph bodies was not in the question. Okay. So there was no pseudomorph bodies in this question. So let us remove this nuclear groove or pseudomorph bodies. In this, eosinophilic cells were present. Now the point is, if this eosin or the pinky story was inside, then it goes in favor of follicular. But if it is outside, then it goes in favor of medullary. Right. So meningioma, we had a question related to pseudomorph bodies, pathology question. Right, Dr. Daksh. Thank you, beta. So basically, whether it was inside or outside, based on that, we will have to differentiate, because a variant of follicular cancer, which is a Hurthle cell tumor, therein we can find this Okay. Solitary hard nodule was there. Fine. Okay, Dr. Yash. Right, beta. So whether this eosin was inside or outside, based on that we can decide whether it is follicular or medullary. In medullary, they should have given something related to amyloid stroma, calcitonin, CA, serotonin or something, but nothing. Then we should go in favor of follicular thyroid cancer if there is any doubt. Intracellular, then we are going with a follicular thyroid cancer. Right. Fine. Then there was a histopathology image of a mucinous breast cancer also, though I do not have that image, so I did not frame anything on that as such. Now, all the lovely doctors, beta, I hope you would have enjoyed this question in the examination hall. A patient was brought to the hospital after road traffic accident. He was conscious but confused and was able to open his eyes on voice command. On clinical examination, he was able to localize the stimulus. What can be the most likely Glasgow coma scale in this patient? Right. Wonderful, wonderful, wonderful. All going good? Great. So international villagers, Savan, Yesh, Dr. Alam, Deepik, Dr. Harsh, Dr. Kishore, all of you are absolutely correct, beta. The correct answer is 12, right? Because here we know eye opening, spontaneous is 4. Akole, on voice command it is E3, and on painful or pressure stimulus it is E2, and no opening of the eyes is E1. So here he is opening the eyes on voice command. So this is E3. Verbal, if he is fully conscious, oriented to time, place and person, it is V5. If he is confused, it is V4. If he uses abusive language, inappropriate words, गलत शब्दों का इस्तेमाल करता है, तो this is V3. And if he is not able to speak out any words, he is just making some sounds, शब्द नहीं निकल रहे, सिर्फ आवाज आ रही है, then it is V2, and if no sound, then it is V1. So here he is confused, so we go in favor of this. Wonderful. And motor ka, if he is able to obey all the commands, that is motor 6, localize is motor 5, and withdraws or normal flexion is motor 4, abnormal flexion is motor 3, extension is motor 2, and no movement is motor 1. So 3 plus 4 plus 5, that is 12. You are absolutely correct, beta. Wonderfully done, all the lovely doctors. God bless you all, beta. Another question. Young male suffered a blow to the upper chest, or instead of this young male, they would have given a history of a boy suffered a blow to the upper chest with a fist. Wonderful, Krishna. Well done, beta. Wonderful. After the injury, he developed sudden difficulty in breathing with dilated engorged neck veins, hypotension and diminished breath sounds on one side. There was hyperresonance on percussion as well. X-ray image showed the following. What is the likely diagnosis? So, if suppose these were the given options, out of these given options, I think, Nikhil, wonderful, beta. So if these were the options, then obviously it is not a case of cardiac tamponade because there was hyperresonance on percussion. In cardiac tamponade, there would be muffled heart sounds, there would be fluid around the heart, and obviously diminished breath sounds will not be there. Hypotension and engorged neck veins will be present in both cardiac tamponade and maybe in traumatic tension pneumothorax type of story, right? So in the given options, the answer would go in favor of traumatic pneumothorax, right? I hope they did not give two options, one as traumatic pneumothorax and one as tension pneumothorax. I hope these were not present in the 4 options for the same question. Tracheal deviation tha, wonderful. So there was tracheal deviation in the question. Tamponade was not there. Okay, so tamponade was not there. Hanji beta, the international villager, they are actually increasing the standard of the papers. Right? So conceptual understanding, Wonderful. Dr. Yash, tension pneumothorax was there in the option or not? No. Whether tension pneumothorax and traumatic pneumothorax, क्या ये दोनों अलग अलग ऑप्शंस में थे? टेंशन नहीं था. सो मेजॉरिटी ऑफ यू आर सेइंग बेटा कि टेंशन नहीं था. सो आई थिंक if these were the options, wonderful beta. So all of us are on the same page. Great. So the correct answer will be traumatic pneumothorax. Traumatic pneumothorax beta, any type of trauma can lead to tension pneumothorax also. It can lead to a simple pneumothorax also. It can lead to tension pneumothorax also. This particular case, the trauma has caused tension pneumothorax. Okay, either one of them, even if either one of them is there, that is the correct answer for this particular question, right? Now, there was a image of a child with the burns, right? Though this is not the image which you would have got in the exam, but I've just tried to explain this question or to discuss this question. I've taken one image of a baby. There is fight in the bar. Okay, beta, exploring word. Blow to the upper chest with a fist. After a fight in the bar. Thank you, beta. Thank you. Right. In this, one option was 20 to 30%. Okay. Wonderful. So, as we all know, beta, the rule of 9, we know. 9 for the head and neck, 9 front of chest, 9 front of abdomen, 9 back of chest, 9 back of abdomen, 9 for one complete upper limb, 9 front of one lower limb, 9 back of one lower limb. Now, if he's saying that some part of right thigh, right upper limb and right thigh is what I could gather. So, if this is the game, beta, my calculation would say that okay, one option was 18 to 20%. Okay, 18 to 20% was there, then 20 to 30% was there, then 40 to 50% was there. Okay, and another option was 5 to 10. Upper arm, leg, thorax, abdomen. Now, I would like to know how you were able to decide. Were you supposed to decide looking at the image, or you were supposed to decide based on what is written in the question? Image or question language? Right leg was there. Okay. Leg front, chest, abdomen, half of upper arm. One leg, one hand, thorax, abdomen, face. Rule of 5. By looking at the image, right? So all the lovely doctors, you are on the same page, beta. That image you were supposed to decide. Now, what we know is, if suppose this area is involved, and what was the age of this baby by looking at the image? 50 to 60% was there. So should I change this option to 50 to 60, beta? Half body banti, half face and upper hand, half till diaphragm. Okay, so should I include this area like this and face as well? Anterior upper and lower body, deltoid region, and one anterior full leg. One anterior full leg. Okay. Likely less than 10 years. Okay, so age was not given, but maybe less than 10 years. So let us believe somewhere around 6 to 8 years of age. If it was 10 years beta, then the game is just like an adult. Face nahi tha. Okay, so we'll just remove the face. Not full chest. No face. Okay. Okay. Now, half chest, half abdomen, leg, thigh with below knee. Okay. Suppose this is the game, then here this will be 9%. This we'll take as if half upper limb is burnt, half chest, half abdomen, leg, thigh with below knee, right upper arm. So this would be somewhere around 4.5%. If the only the front of the arm is there, then it will become 2.25. Only front of the arm. If only front of the arm is there, then it will be 2.25. If whole of the arm is there of one side, then it is 4.5%. कोई बात नहीं बेटा, थोड़ा सा इस पे टाइम लगा के अपर हाफ ऑफ द आर्म, हाफ चेस्ट, हाफ एब्डोमेन एंड एंटीरियर राइट थाई. ओके, तो हम इसी पे फोकस करते हैं अभी. अगर एब्डोमेन भी आ रहा है, सारे बच्चे बोल रहे हैं, तो लेट अस टेक दिस एज वेल एज 9. तो ये भी हो गया. और अब आती है अपनी थाई की बात. अगर हम एंटीरियर साइड की बात करते हैं, फ्रंट ऑफ वन लोअर लिम्ब इज 9, तो हम इसको ले लेते हैं 4.5. अब यहाँ पे गेम क्या है बेटा कि अगर सिर्फ फ्रंट ऑफ थाई ही है, एंटीरियर राइट थाई, विदाउट दैट एक्चुअली में इट्स डिफिकल्ट टू रूल आउट. कंप्लीट हैंड था, कोई बात नहीं बेटा. अगर हम मान लो फ्रंट ऑफ चेस्ट, फ्रंट ऑफ एब्डोमेन, फ्रंट ऑफ राइट थाई एंड राइट आर्म लेते हैं, तो 9 + 9 इज 18 एंड 18 + 4.5 + 4.5 दिस मेक्स 27. अगर हम इसको इस तरह से लेते हैं जो हम देख रहे हैं. लेकिन अगर इसमें कोई भी डेविएशन है, जैसे सपोज करो 1 कंप्लीट अपर लिम्ब आ जाए, साथ में 1 कंप्लीट लोअर लिम्ब आ जाए, तो द गेम विल चेंज. राइट. ओके, एंटीरियर थाई एंड लेग बोथ था, तो दिस विल गो टू 9% तक पहुंच जाएगा. डॉक्टर दक्ष इज सेइंग ओनली फ्रंट था, राइट. तो वॉट एवर इट इज बेटा, क्योंकि यू हैव सीन विथ योर आइज, so you would be the best judge, and let me not comment on to this just to give you the answer. That is not my job beta. कि मैं कोई भी ऐसा वैसा आंसर नहीं देना चाहता, है ना. जो वहाँ पे आपको दिखा बेटा, you have done right because you know the concept. तो उससे जो आपने देखा उसके हिसाब से आपने लगाया और वो सही रहा होगा. So I just believe in this. Right. Okay, चलिए. Now, another question, beta. A patient presented with abnormal dilated tortuous veins over the leg, clinically falling into C6 category. Which of the following is correct in this patient? Compression, stockings, and sclerotherapy should be recommended treatment. Endovenous thermal laser ablation is the best modality. Stripping of the dilated vein should be the most preferred method for treating this pathology. Deep venous system is affected more commonly. Okay. Right, Dr. Richard. Acha beta, can you help me in this particular question? A patient presented with varicose veins की game है. अब falling into C4A था या C6 था? तो what was it? Whether it was C4A or C6? Okay, so we are not able to remember that, right? Fine. Okay, so Dr. Harsh, Dr. Sunil has said C6. Fine. Dr. Prajwal is also saying C6. So beta, what will be the answer for this? most common involvement of great saphenous vein. Okay, beta. Fine. Now, if which of the following is correct in this patient? So, most common involvement is the great saphenous vein. Yes, that is right. Actually, it is the saphenofemoral valve incompetence, which is the most common incompetence. Saphenofemoral valve incompetence, which causes blood flow from femoral vein into the long saphenous vein. So blood is coming from the deep to the superficial, and that is why the great saphenous vein becomes dilated and tortuous, right? So Dr. Daksh, epic, yes, absolutely correct. This is the right answer for this. However, if they're saying most commonly involved is the great saphenous vein, then yes, that is also the correct answer, but it is due to saphenofemoral incompetence, right? Fine. So no controversies, and this is also settled, right? Okay, beta. Now another question. There are these 2 to 3 questions from breast, where probably what I'm feeling is I might have mixed these breast questions. So please do help me out on this and correct me wherever I'm going wrong. This is a 28-year-old lactating female presenting 2 weeks after delivery with a 3 centimeter subareolar mass in her right breast. Here the game is important, beta. The mass is associated with redness, tenderness, and mild warmth. Now, whether this was there in the question or not, because this will change the game. She reports no fever, but mentions difficulty in breastfeeding from the affected breast. What is the most likely diagnosis? Now, whether redness, tenderness, or mild warmth was there in this question or not, that is what we have to figure out. So, Dr. International Villager, options were same. Okay. Dr. Sunil, Dr. Kanchan, Dr. Harsh. Okay. If this redness, tenderness, and mild warmth is there, beta, then it goes in favor of lactational mastitis. But if this redness, tenderness, mild warmth is not there, then it will go in favor of galactocele. That is what is happening with me also, Dr. Tariq, that there were 3 different type of questions, right? So whether lactational mastitis was there in the option or not, now that is also a big question mark here, right? If there was something else, suppose instead of lactational mastitis, there was breast abscess in the option. Dr. Mohammed is saying mastitis is not in the option. So you marked a galactocele. Wonderful. So beta, if mastitis was not there in the option, then galactocele would be the preferred answer. If breast abscess was in one of the option, but if the patient does not have any fever, then breast abscess will also not be the most appropriate. Okay, so breast abscess was there in the option. Dr. Kanchan is saying mastitis is not there in the option. हाँ, एक और क्वेश्चन है बेटा अक्षय, वो एक बार एक काम करते हैं, उसको भी देख लेते हैं. डॉक्टर दक्ष, if you have marked galactocele, then definitely I feel the lactational mastitis would not have been in the option, and so the correct answer would have been galactocele, right? And Dr. Tariq is saying कि ये क्वेश्चन था and mastitis was also in the option. So basically the game is, if there was redness, tenderness, and mild warmth, and lactational mastitis was in the option, then mastitis becomes a better answer. If lactational mastitis was not in the option, then galactocele becomes the best answer. Fibroadenoma is ruled out. Mondus disease is just thrombophlebitis of the superficial vein of the skin of the breast and the chest wall. Right. So let us see the other question also. For this particular question, if mastitis was not there and breast abscess was there in the option, then the answer goes in favor of galactocele. Now let's see another question, beta. A 35-year-old woman presents with a 3 centimeter subareolar mass in her left breast. She reports bloody nipple discharge but denies pain, redness, or systemic symptoms. On examination, the mass is firm and non-tender with no signs of inflammation. What is the most likely diagnosis? Or in this, what we can do is we can make one of the options as maybe ductectasia. We can write one option as ductectasia. Please do correct me wherever possible, beta. Right, so we are seeing these two questions. DCS नहीं था. Okay, so there was no DCIS in the option. Now if you can just figure out the two questions. If, yeah, for this, if there was a bloody nipple discharge, then the answer goes in favor of duct papilloma. Right. Okay, fine. So these were the two questions. A fibrocystic disease was there. So was fibrocystic disease. Okay, so ductectasia भी नहीं था. Okay, fibrocystic disease. Fibroadenoma was in the option. Okay, so let's take it as fibroadenoma here. Okay, so basically moral of the story, if there is a bloody nipple discharge, then out of the given option, the diagnosis goes in favor of papilloma. Right. One more, boy history breast disease. Okay. Yeah, now I remember that somebody was talking about this, but I failed to write that particular question. Dr. Simple, you are absolutely correct, I feel. Okay, so we'll just find it out. We'll figure that out once all the questions are there, all the questions are done. Identify the correct option, beta. Now, in this particular case, they just want to know what is the correct option, right? So here they have mentioned something like this, that this is the floor, this is the base, this is the edge, and this is the surface probably. Okay, let's see whether this let me hear from you, beta. That was this type of question there in the exam? Okay, Dr. Daksh. No images there. Okay. Right, Dr. Richard, Dr. Sawan, Dr. Daksh, wonderful. Okay, right. So suppose they wanted to know what is correct. So let's see what is actually correct. Now this is what is correct, beta. कोई भी अल्सर होता है, सपोज ये जो हमें दिख रहा है ना, दिस इज द अल्सर. अल्सर इज अ ब्रीच इन द कंटिन्यूटी ऑफ एपिथेलियम. तो बेटा ये जो अल्सर जिस पे रेस्ट करता है, दैट इज द बेस. और जो हमें ऊपर से दिखाई देता है, व्हाट वी आर एबल टू सी फ्रॉम अबव, नाउ दिस बिकम्स द फ्लोर. बेसिकली this is the floor, right? So this becomes the base, this becomes the floor, and this is the edge of the ulcer. और edges पे बहुत सारे questions पूछते हैं बेटा ये लोग कि sloping edge is seen in inflammatory healing venous ulcers में, undermined edge is seen in tuberculosis, punched out in syphilis, rolled out beaded in basal cell carcinoma, and raised everted in squamous cell carcinoma, right? Okay. Image was there, almost similar. Must be a hand-drawn diagram. Okay. So Krishna, thank you, beta. Thank you so much. If you can gather a little more information related to this, Krishna, please do ping me on my WhatsApp as well. Right? That child, the boy with a breast lesion, and asking which of the following management is more effective, right? Okay. So beta, this what we are seeing is the correct. Now what they gave there, ऑप्शन में दे गिव सरफेस. दिस वाज द क्वेश्चन, है ना बेटा. ये सही है जो हम देख रहे हैं, दिस इज द राइट थिंग. और जो वहां उन्होंने दिया वो ऐसा कुछ दिया शायद. तो बेटा उन्होंने बेस को लिख दिया फ्लोर और फ्लोर को लिख दिया बेस. एज सही मार्क किया और ये जो मार्जिन होती है इसको लिख दिया उन्होंने सरफेस बेसिकली, है ना. तो ये मार्जिन को उन्होंने बेसिकली सरफेस लिख दिया. तो एज वाज करेक्ट, एब्सोल्युटली राइट. So edge was the correct answer for this. Right. Wonderful. Thank you, Dr. Krishna Beta. Right. And then there was a question something like this. A patient presented with a swelling having clear viscous gelatinous fluid inside as shown in the image. What is the likely diagnosis? ऐसा था बेटा कोई question? Something related to this with a swelling on the dorsal aspect of hand. Right. Dr. Tariq, Dr. Ravindra. Okay, Dr. Tariq, if it would have been base, okay. Dr. Ravindra, yes, you are absolutely correct. All of you, all the lovely doctors, beta. It's a ganglion. Okay, fine. Image would have been different, right? Oh. Okay, so image is also closely resembling this. Wonderful. That's right, beta. So this is a ganglion, and this is generally ganglion is something which is related to tendon sheath, where there is collection of that gelatinous fluid within the tendon sheath, and commonly seen over the joint areas. Yeah. Dr. Nevlin, I'll be coming on to that sebaceous cyst question also. थोड़ा और नीचे था, फिस्ट पे था. ओके, मतलब somewhere here. Dr. Zishan, basically it is on the similar patterns what we have been seeing in the previous years as well. So when we give the exam, we definitely feel that it might be a lot tough. But all the lovely doctors, beta, one thing which I would like to salute you all, that the knowledge what you gain by attending the classes, that knowledge, the concepts what you are building up now, that helps you in marking the correct answers. So when you will be seeing the results, my personal opinion, maybe I am wrong, but I feel the pass percentage should be somewhere around 20%, 25% as far as this particular paper is concerned. In this question only sebaceous cyst was there, Dr. Daksh. Okay, so instead of hematoma, let me mark this as sebaceous cyst, and gelatinous, Dr. Webb of they mentioned, right? Okay, fine. Okay, beta. Now let's take a look at another question. I think there was something similar question, something like this. A 30-year-old male presents with persistent swelling and discomfort over the dorsal aspect of the middle phalanx of the middle finger. He reports a history of penetrative trauma to the area a few days ago. Examination reveals a firm tender mass with limited mobility of the distal interphalangeal joint. Image is shown below. If left untreated, what is the most likely complication? Okay. Now, the given options are gangrene of the fingertip due to compromised vascular supply, frog-like deformity of the finger caused by chronic inflammation and tendon dysfunction, Then injury to blood vessels during wound cleaning leading to ischemia. Secondary infection requiring removal of the nail bed. Okay, so something like this question was there, I guess. One option was involving the synovial joints. Yeah. So should I change this gangrene of the fingertip? All right, Dr. Daksh. So swelling was not there. Okay. Finger was abducted. Okay, Dr. Krishna. Yeah, synovial joint, somebody, I remember that somebody told me, but I did not write this. No swelling in the image, so the image is different. Injury was on the lateral side of the finger near proximal interphalangeal joint. Okay. That means the problem here would have been somewhere in this area. Okay, fine. Right. So looking at these options, if we just try to see what is this frog-like deformity or what is this foreign body granuloma basically, in penetrating traumas, frog-like deformity can be caused by chronic inflammation and tendon dysfunction. This can affect the tendon function and joint stability, resulting in deformities like frog-like, characterized by flexion at both the proximal and distal interphalangeal joints. So out of the given options, though all of the mentioned can be correct, but if we want to reach on to the most appropriate one, like gangrene of the finger due to compromised vascular supply can occur, but there was nothing, no evidence to suggest that there is a vascular compromise because there were no evidence of any gangrenous changes on the tip of the finger. Now, injury to blood vessels during wound cleaning, again, aggressive cleaning can cause injury to these blood vessels also, but it is not directly related to the pathology of foreign body granuloma. So, if we have to choose between that frog-like deformity and injury to blood vessels during cleaning, we'll prefer choosing frog-like deformity because it is more closely related to the foreign body granuloma because he's telling us something about a penetrating injury. तो बेटा कुछ चीज पेनिट्रेट की होगी अंदर, हो सकता है कोई फॉरेन बॉडी अंदर ही रह गई हो, राइट? तो इस वजह से ऐसा हो सकता है. तो अकॉर्डिंग टू मी maybe I can figure out even better. Fingers were straight. There was no flexion. Okay. Okay, beta. Thank you very much. Thank you so much. Thank you, Dr. FS10, beta. Right. So, you can even mark that C option if you think that frog deformity was not the fitting answer there, right? Okay. 35-year-old male presents with 3 centimeters soft, non-tender, fluctuant swelling on the upper back. The lesion has been present for several months. Where is the image gone for this? Oh. Okay. I'm so sorry. The image has not come in this, but there was an image where we were able to see a cyst. And in that cyst, basically, we were able to see a black punctum, something like this, right? So that was I remember that wide local excision was also one of the option. Wide local excision, right? Thank you, beta. Thank you very much. Wonderful, Dr. Bhanu Beta. Thank you so very much. God said, thank you. I think this is the question you are talking about. Sure, Dr. Harry. I'll try to add few things in this, especially in this area like ganglion. Ganglion is a topic related to orthopedics as well. So definitely I would be including these ulcers, cysts, and all. Right. Thank you for your feedback, beta. Okay, so here the answer is complete surgical excision of the cyst. Wide local excision is not required in this. And if there is no infection, if there is no abscess here, then incision and drainage. Yeah, there was an image. In fact, I also put that image, but unfortunately, it's not there in the iPad. It would be in the laptop. Anyways, thank you, Dr. Bibu. Right. So for this, if there is no abscess, then no incision drainage is required. Antibiotic therapy, just conservative treatment. There is no infection here, so no need for any antibiotic or something. And surgical excision, it's not a malignancy, it's not a sarcoma, so there is no need for any wide local excision here. Yeah, Dr. Harry, I've taken your feedback, beta, and I really say thank you to you. I would definitely be adopting this. What can be the likely pathology in the patient whose image is given below? Was there some image like this, beta? Can you help me out in this? Was there something like this? Anti-inflammatory drugs. That means, Dr. Bibu, there was some supportive treatment, right? God did, beta. That was a sebaceous cyst. Sebaceous cyst has got a black punctum in this. Dr. Zishan, if there is a white cheesy liquid, wonderful. So in sebaceous cyst, there is a white cheesy liquid. But if it is associated with signs of inflammation, rubor, tumor, calor, dolor, associated with some fluctuation, then it becomes an abscess, beta. But if that is not there, if it is just a swelling with a black punctum, then it is non-infected sebaceous cyst, which will require excision. If it is just redness, then it will require supportive treatment and antibiotics. If there is a pus collection, fluctuation is there with pus collection, then incision and drainage will be required, Dr. Zishan. The swelling was much bigger. Okay. 3 times more bigger swelling than this. Okay. Fine. So, anyways, though I have got one image related to incisional hernia, let me just try to see if I have it here or not. Let me just check if I have got that particular image. No, I don't think so. Right. So if we are not having the correct image, what answer did you mark, beta? Anyways, if this was not the image there, just for my idea, did you answer abdominal aortic aneurysm or you answered pseudocyst of the pancreas? Right. Thank you, Dr. Nikhil. Thank you, Dr. Pooja. Right. 3 to 4 times more. Okay. There was one option as bowel ischemia, I guess. That's right. Small bowel ischemia. Okay. Okay, beta. So we do not have the image, so we'll not be able to comment about it. But depending on if it was a massive swelling, it can even be a pseudocyst. Redness was there. So I think if there is any bluish discoloration signs of pancreatitis beta, then it goes in favor of abdominal aortic aneurysm, because you remember that in acute hemorrhagic pancreatitis, we see Gray Turner sign, Cullen's sign, and Fox sign. So that is a bluish discoloration. That is because of blood leaking from the retroperitoneum into the anterior abdominal wall. So if there was something like that, then aortic aneurysm would have been a better answer. Right. History of laparotomy was there. Okay. And was the age given in the question? And they asked complication. History of hysterectomy was there. Only and only massive swelling is there. See, if it would have been a bowel ischemia or bowel obstruction, then we would have seen a grossly distended abdomen, not a different swelling. पूरी की पूरी abdomen की दीवार जो है ना, वो पूरी उठ जाएगी अगर वो bowel obstruction से relate कर रहे होंगे तो. और अगर ये pseudocyst of the pancreas है जो बहुत बड़ी हो गई है, it might be projecting as a swelling, or even very big aortic aneurysm may be presenting as a swelling. After hysterectomy, so must be an elderly. So I think if they're trying to relate with the age, then it will go in favor of aortic aneurysm. Right. Okay. So apart from this beta, there were few more questions. The 12 questions which were overlapping questions, which I have not included in surgery discussion. Okay. So एक level 2 cervical lymph node था बेटा. So ENT और anatomy classes में 1A submental, 1B submandibular, 2, 3, 4 upper middle lower deep cervical lymph nodes, 5 posterior triangle, 6 pretracheal delphic, or 7 mediastinal. Right. So depending on what they asked, generally the students are saying they asked the lymph node at the top of the sternomastoid. Right. Life at risk. Then definitely all the lovely doctors beta, because you have got the great concepts inside. So you would have chosen the right answer, I'm sure. Right. Then there were two questions related to foreign body. One in the larynx trachea. One they asked you to identify where is the foreign body. And another question where they asked that Heimlich maneuver, what you are going to do in this. And if it was a small baby, then Heimlich would not have been done in that case, right? So they were ENT related question. Then there was a pathology question related to pigment gallbladder stone, and they asked probably what is the least likely cause. So that HBD Punjab is probably the answer for that. Then anatomy question, they asked you to locate whether it was cystic artery or the right hepatic artery. There's a confusion going on, right? Then hammer injury forensic, sir has already discussed that question, depressed skull fracture. Then there was a image based question related to phyllodes tumor probably, right. Then there was another anatomy question related to breast cancer surgery, where you were asked to identify the muscle. So whether it was serratus anterior or latissimus dorsi, ma'am has taken that in anatomy. Pathology, meningioma, psammoma bodies question, direct question was there, mucinous breast cancer. Then Bochdalek hernia was there related to pediatrics. Marker for acute pancreatitis, serum lipase I think was there. Bloody discharge from nipple, Dr. Sayed, is duct papilloma. And there was one question which I saw somewhere, but I'm not sure whether it was there or not, because nobody has told me about this repeated gastric ulcers in Zollinger-Ellison syndrome. So if we look at whatever questions we have discussed in detail, the number of those questions is 31. And apart from that, there were few overlapping questions and maybe 1 or 2, 3 questions I would have missed out definitely. So overall, I feel that if they are asking 32 questions from surgery, and if we have got some overlapping questions as well, and if suppose there are 40 questions, there was, okay, thank you, Dr. Ganesh. It was there, Zollinger Ellison. Thank you, Vita. Wonderful. So out of those 40 questions, even if you have scored somewhere around 25 to 30, then also I feel that you have done a wonderful job in this type of surgery paper if we are making it from 40. And suppose if we consider only 32 questions from surgery, and if you are able to score 20 to 25 out of 32, that's also a wonderful, decent score. Thank you very much for your patience, Vita. Thank you so much, all the lovely doctors, and a wonderful, lovely thank you. Just relax yourself, enjoy. These are your days, and you're definitely going to rock. Just keep on praying to God. We all will be praying to God for you, that may God reward all your hard work, and may God bless you all with all the flying colors with a good score. Let's keep hoping. Enjoy, relax yourself, and please do share the feedback related to this FMG recall on my personal WhatsApp or in this YouTube video comment section. Thank you very much. May God bless you all. Signing off. Breast stating swelling in the upper inner quadrant. Was that discussed? No. Yes, that is the question which I would be waiting, Dr. Sayed. There was a boy with a tumor on the lateral surface of the breast. Thank you, beta. Thank you very much.